are you in New York? Am I remembering that?
Yeah. Yes.
You're in New York. Okay. Cool.
And
Where?
this is exactly what we're going to be working on, the decarbonization
awesome.
in the healthcare sector. And we're in the process of starting our new organization, New York Clinicians for Climate Action.
That's awesome.
And 4 of us are climate health organizing fellows with Cambridge Health and Harvard.
Oh, cool.
So
that's awesome. Where in New York are you?
I live in Long Island. I practice in Queens.
Cool. I grew up in Westchester, so not too far.
Not too far. No.
Yeah, cool. All righty. Give everybody 1 more minute.
So you have national reach, at least, if not international.
Yeah, that's awesome. Hopefully this will be helpful.
Yeah. Thank you. Yeah. That's Ashley. All righty. Well, let's go ahead and start, and then we'll just keep admitting people as needed. Thank you all for being here. I'm Amanda Milstein. I'm a primary care pediatrician in Richmond in Northern California and one of the co-founders of Climate Health Now. And it is an absolute pleasure and honor to introduce Dr. Bill Pevec, who is here with us today, who is Professor Emeritus of Vascular Surgery at UC Davis School of Medicine. I'm going to try to hit, Bill, the highlights of your bio here. So Bill did medical school at University of Cincinnati College of Medicine, residency at University of Pittsburgh, and a fellowship at Mass General, and started at the Department of Surgery at UC Davis in 1992, and was chief of the Division of Vascular Surgery there from 1999 until he retired 4 years ago. And he is now the volunteer and docent coordinator for Stebbins Cold Canyon Natural Reserve, a member of the steering committee of the UC Davis Polar Forum. I'd be curious, I don't know what that is, but I'm curious to learn. A faculty mentor for the Sustainability Through Environmentally Thoughtful Healthcare student organization. He was recognized with a Faculty Champion Campus Sustainability Award by the UC Davis Office of Sustainability in 2020. He's a member of the UC Davis Health Sustainability Committee and the Waste Reduction and Operating Room Sustainability Subcommittees. And last but not least, he's an active member of Climate Health Now. All righty, Bill, I'm going to turn it over to you, and you should be able to screen share.
All right, thank you, Amanda, for the nice introduction. And so you should be seeing my slides, yes? Okay, thank you so much for allowing me to present to you today on healthcare sustainability. I have no financial interest in any topic discussed, although I do like to disclose I'm not an expert in any of these topics. I'm a retired vascular surgeon, not a climate scientist or a hospital administrator. And I will skip the other disclosures here because Amanda mentioned all of these in the introduction. So about 6 months ago, the editors of 220 medical journals simultaneously published an editorial that acknowledged that the global temperature increases and loss of biodiversity are an emergency, that these were affecting the health of people, and that calling on the leadership of nations to address these 2 issues, which was an incredible good thing. But to my disappointment, nowhere in that editorial did they mention the role that healthcare plays in the problem. Healthcare is responsible globally for 4.4% of all greenhouse gas emissions. If healthcare were a nation, it would be the 5th largest emitter of greenhouse gases in the world. And those emissions are equal to the output of 514 coal-fired power plants. This impact is not equally distributed across the world. It's primarily a problem with the advanced economies in that United States, China, and the European Union comprise 56% of the global healthcare climate footprint. And on a per capita basis, far and away, the United States is the biggest problem. Our healthcare causes more climate emissions, more carbon emissions than any other country on a per capita basis. And it's been reported that the emissions from US healthcare alone are greater than the emissions of the entire economy of the United Kingdom. The greenhouse gas emissions are typically described in 3 different scopes, and this is done for healthcare as well. Scope 1 comprises the direct emissions that come from the facility and the vehicles owned by a facility. That's the on-site energy use, fleet vehicles, peculiar to healthcare that waste anesthetic gases and also leaking refrigerants. So those scope 1 emissions make up about 17% of healthcare emissions. Scope 2 are the emissions due to the energy that healthcare facilities purchase from utilities like electricity and steam. That makes up about 12%. And scopes 1 and 2 are the scopes that are easier to measure, easier to understand, and at least more able to be directly affected by an institution. So the scope 3 emissions are the ones that are actually harder to measure and harder to address. And unfortunately, these make up a whopping 71% of the healthcare emissions. And this includes the carbon that's embedded in how we do business. It's the travel of our employees and our patients to our facilities. It's a business travel. It's the food we produce in our facilities and the waste we dispose in our facilities, and also the stuff we use to take care of our patients, the medical equipment and devices and the pharmaceuticals. And again, 70% of the carbon footprint of healthcare is wrapped up in these scope 3 emissions. But interestingly, it's not just greenhouse gases emissions that are the problem. US healthcare also is responsible for 9% of the country's air pollution, 12% of the country's acid rain emissions, and 10% of the smog forming emissions. And based on at least one study, these air pollutants cause the loss of 470,000 disability adjusted life years every year. And to give them that some perspective, that is almost exactly the same amount of lives lost that were attributed to medical errors 20 years ago. The Institute of Medicine published this report in 2000, attributing all these deaths to medical errors, made a huge splash, became a central focus in healthcare facilities to reduce errors and keep our patients safe. Yet we don't see this kind of excitement and interest being placed into the air pollution that we contribute. And it's not just emissions. The average US hospital generates more than 4.7 million pounds of waste every year. That works out to 6.5 tons a day, which is mind-boggling. And a big medical center like the one where I work puts out 15 tons of waste every single day. I mean, I've had to recheck that number so many times that it seemed like it's too much, but that is actually accurate. Every single day, 15 tons of waste. And in the United States, we spent $5.9 billion of our healthcare dollars just managing waste alone in 2014. It's not just that we make a lot of waste, but the way we work is also very wasteful. Study published in 2019 looked at 4 different eye practices, surgical ophthalmology practices, and found that 45% of drugs for surgical procedures are wasted at the end of every case. And they looked at 2 of those practices that added up to $190,000 of drugs wasted every year. In the neurosurgery department at UCSF looked at the waste in their operating room, and they found 13% of supplies were unused at the end of every case. Cost of $653 per case, which added up to $2.9 million wasted in the neurosurgery ORs at UCSF alone. And it's not surprising that these 2 studies looked at OR waste, because if you look at a hospital's waste, the perioperative settings generate about 70% of the total waste in the entire hospital, and they consume 3 to 6 times energy per square foot compared to the rest of the hospital. So if you want to make an impact on your hospital and its environmental footprint, you really do have to address the perioperative services. And to give some idea how wasteful we are in the way we do things, this is a report of this Everend Eye Center, eye care system, which is located in India and performs state-of-the-art eye care at 1/10 the cost, developing 1/10 of the solid waste and 1/20 of the carbon emissions compared to similar practice in the United States. And they reportedly did this by studying how McDonald's got so efficient, and they got commanded their supply chain, and then they standardized their processes, including optimizing the flow of their patients and supplies, task shifting to effectively utilize their trained staff, minimizing and standardizing the materials they used in the OR, and selecting reusables whenever possible. So the World Health Organization addressed this issue and stated, as medical professionals, our commitment is first, do no harm. Places of healing should be leading the way, not contributing to the burden of the disease. And even the AMA has supported physicians adopting programs for environmental sustainability in their practices. So they're saying this is something we should be doing. And I agree, this is something we should be doing. So that's an introduction to the problem. What I'd like to do for the bulk of the presentation is tell some stories or give some case studies of things that we've done in my own medical center. And I chose to approach it this way because we had breakout sessions at the Climate Health meeting a couple months ago, Climate Health Now meeting, a couple months ago, where we got into breakout sessions, including the group that wanted to work on healthcare sustainability. And there seemed to be an undercurrent of uncertainty of how to start. A lot of people wanted to help, but didn't know where to start. So I'd like to give some examples of things we've been working on for the past year and a half. And we're going to talk about reusable versus disposable gowns, reprocessing of devices, regulated medical waste, blue wrap, anesthetic gases, energy use, food, and then briefly discuss some other efforts. So the first example I'd like to give is reusable isolation gowns. So at the beginning of 2020, when COVID-19 hit, the hospital recognized we had a significant concern with supply chain. Were we going to be able to purchase the disposable gowns, isolation gowns that were in increased use with the pandemic? And it turns out that getting rid of disposable gowns would potentially have an environmental benefit. And we jumped onto this initiative because of the environmental concerns. And this slide here, this graph comes from Practice Green Health, and it's based on a study published in 2018 in the American Journal of Infectious Disease. And it's looking at a life cycle assessment for 1,000 gown uses. And in green are the disposable gowns, in white are the reusable gowns. And not surprisingly, using reusable gowns cuts down dramatically on solid waste generation. Maybe surprising to some, even though you have to launder reusable gowns, the water consumption is higher for the production of disposable gowns than laundering the reusable gowns. And reusable gowns consume less energy and lead to fewer greenhouse gas emissions than using disposable gowns. So better for the supply chain, better for the environment to switch from disposable to reusable. So we planned a pilot project starting in the pediatric ICU. We estimated the number of gowns that we use in a day. We found out how much it would cost to purchase those gowns and to launder them versus the purchase price of disposable gowns, and projected we could save the hospital a bit of money if we made this transition. So we developed a 6-month pilot. It did require some logistics to work out and how we are going to distribute these gowns, how we're going to collect them as opposed to trash, with laundry as opposed to trash. And we did a user survey to find out how the staff would accept the reusable gowns. And this is the results of that survey, with 4 being very satisfied, 1 being very unsatisfied. Environmental impact scored a very satisfactory response, as did patient safety. Personal safety was a little bit lower, and that was primarily the first iteration of gowns we used did not have thumb holes on the sleeves, and the users felt the sleeves are too short, so their wrists were getting exposed. So we went back to the vendor, and we had them manufacture gowns with longer sleeves with thumb holes, and that took care of that problem. Ease of donning and doffing was still more positive than negative, but that was the most negative score, and that's because the paper gowns, you just put a toilet seat ring over your head and you rip them off when you're done. Reusable gowns, you have to snap in the back. So a little bit, you're not going to get away from that, a little bit more cumbersome to put on and take off. So we looked after that trial, we did that 6-month trial, it seemed to be satisfactory. And so we looked at what happened if we would do this hospital-wide. And in the year before the pandemic, 2019 to January 2020, we used about 1 million gowns. We almost doubled that to 1.9 million gowns from March 2020 to February 2021 with the pandemic. So our use of these gowns went up dramatically. And we did a similar analysis, estimating 1.5 million gowns per year, a number between those two. And if we used a 1.5 million gowns per year and switched from disposable to reusable, we would save the hospital $127,000. So based on the positive results of the pilot study and the cost analysis, we were able to get our product standards committee to approve the use of reusable isolation gowns hospital-wide because they're better. They give us a more reliable supply. We don't have to count on the vendor not being able to send us disposable gowns. Satisfaction of the users was adequate, has a clear environmental benefit, and the golden goose, we save the institution money. So based on that experience, we're in the midst now of doing a similar analysis on sterile OR gowns. When I first started working, we used textile gowns. We're now using disposable gowns. We're hopefully going to be able to show that that will be cost effective and start some pilots within the next few months in the OR. Next example I'd like to talk about is reprocessing. And this is something that I think a lot of people aren't even aware of. So it turns out that manufacturers over the last 20, 30 years started labeling lots of items for single use that used to be reusable without changing those devices very much. And the example that I use is this thing in a photo, which is an angioscope. It's a fiber optic scope I would use basically to guide the cutting of valves inside of veins doing arterial bypasses. And we had these reusable scopes that we paid about $6,000 for. And after about 35 to 50 uses, the fiber optics would start to break. You'd have to get rid of them. But I came in one day and we didn't have those anymore. The tech handed me this scope, and this is a disposable scope. Not that different from the reusable scope, costs $2,000 a piece. So it's nice because most of the times the fibers weren't broken. Occasionally we got one right out of the package that was bad, but we throw these away at the end of every case. And for some reason, the hospital bought into that. And we've done that with lots of disposable stuff. We end up actually paying way more money for what seems to be cheaper at the first purchase and more convenient. So it turns out for more than 20 years, there have been vendors that the FDA approves to reprocess certain single-use devices. And these FDA-approved vendors have to show that the quality of the item and the sterility of the item is at least as good as the original equipment. And this is an example of some of the stuff then that can be reprocessed. It starts from relatively simple stuff like tourniquet cuffs or compression sleeves, DVT compression sleeves, alarm pads, pulse oximetry sensors, to more complex things like electrophysiology, cardiac catheters, to even more complex devices like surgical diathermy devices and cutting devices. And reprocessed versus disposable items have a significant environmental impact because if you reuse something rather than just throwing it away, you reduce the resource consumption from the material extraction to make a new device, the significant environmental impact of manufacturing and distributing that device, and then the impact of having to throw away that single-use device at the end of its single use. And also these items come at substantial financial cost to the institution. And to give some example of that, in general, reprocessed devices cost about half to a quarter what the new device is. But for big ticket items like laparoscopic instruments, you can save $1,000 a pop using reprocessed versus new. And similarly, for some of the EP catheters, ultrasound catheters, you can save $1,500 on every device by using a reprocessed device. Sorry. So a question that would naturally come up is, are these good? So this is a report published in a peer-reviewed journal in 2015 on the Banner healthcare system. So at 19 of their hospitals in 7 different states, they did a retrospective review of 7 months of experience where every time a surgical tech, nurse, or surgeon said this device was no good, they kept track of it. And they used original devices and reprocessed devices. And these are two of the more complex devices. This is bipolar and ultrasound cutting devices basically for the operating room. And they found the defect rate for the original equipment was 2% versus the reprocessed devices was 0.4%, highly statistically significant. And that actually seems counterintuitive, but it turns out that it makes some sense. And what the way the authors described it in their discussion on this paper is, number one, every reprocessed device gets screened for that it needs to be functional before it gets reprocessed. So you weed out the small number of lemons that may have come through the first time. Plus, every single reprocessed device gets inspected for quality before being released, as opposed to just a sample for the original devices. So at least based on this study, the reprocessed devices are actually more reliable than the new equipment. And so at our hospital, we collect all sorts of stuff for reprocessing, and we keep track of that. We have 3 different vendors who do our reprocessing. Stryker is the biggest one, and this shows our collection rates for a recent month. We do pretty well in the operating room, collecting about 73% of the possible devices. Not so well in the rest of the hospital, which are at about 38%. So lots of room for improvement there. And then Stryker also gives us an idea how much money we save for the reprocessed devices we purchase. And so currently we're saving about $280,000 a year by buying reprocessed stuff, with the opportunity to save up to $1.2 million a year. And that's primarily if we purchased ligatures, which are one of the more expensive and complex devices. Unfortunately, we currently are contractually obligated to buy those new from another vendor, from Medtronic. So until that we renegotiate that contract, we're kind of stuck. But there is opportunity for significant cost saving if you purchase reprocessed stuff. And another place where we use reprocessed devices and collect them are the electrophysiology lab. And for the last calendar year, we collected about 80% of the catheters available for being collected for reprocessing. And the manufacturers then, or the reprocessing companies, able to reprocess about 50 to 100%. And if you look, most of those, 85 to 100% of those are able to be successfully reprocessed. And then we have the opportunity to purchase those reprocessed catheters. We purchase anywhere from about 1/3 to about 2/3 of those catheters. And in that last calendar year, about 22% of the catheters we purchased were reprocessed. Now, I just found out we're getting pushback from a couple of our cardiologists who don't want to use the reprocessed materials, instruments anymore. So this is one of the things that you need to be aware of. There is always going to be potential clinician pushback on reprocessed devices, and it does require some effort if you want to keep these kind of programs going. And I'm actually planning to meet with those cardiologists again soon and find out what their concerns are. All right, next story is red bag waste, or biohazardous waste, that in our place goes in a red bag. I think most places do that. And it costs more and contributes more greenhouse gases to dispose of red bag waste than standard waste. And the reason for that is standard waste is simply hauled to a landfill. In our case, that's 6.5 miles. The red bag waste is first hauled to an autoclave. In our case, that's 46 miles away. And the autoclave is a very energy intensive process that uses steam at high temperature and high pressure to sterilize that biohazardous waste. And then it's hauled to a second landfill. So it spends a lot more time being moved in a truck and gets that energy intensive autoclaving step in the middle. So we started by educating our staff on what goes into the red bags, and even more importantly, what does not go into the red bags. And then we centralized our red bag containers. So our initial setup was, in every patient room, there was a standard waste bag and the red waste container. And the red waste container was smaller, but it got used as an overflow trash can, got used indiscriminately, really overusing those red bins. So we took those out of the room, replaced them with a red bag dispenser on the wall, took the bin out of the room, and placed those bins in the central solid utility. So if a nurse or doctor is going to get some bloody or contaminated specimen from a patient, they put it in a red bag, tie off the top, and walk it to the central area. In places that generate a lot of red bag waste, like ICUs, we just decrease the size of the red bag containers in addition to the education. And oops, I'm having a hard time advancing my slides. I don't know why. So what we found is over the first 3 years of our experience, we've cut down our red bag waste by 38%, by over a third. And if we look at the first 2 complete years, because fiscal year 2022 is not completed yet, we kept 540,000 pounds of red bag waste out of the landfill, or 270 tons. We saved the institution $108,000, and we kept an estimated 73 carbon dioxide equivalents out of the atmosphere. Next story is blue wrap. So those of you who aren't surgeons, blue wrap is the stuff that is used to wrap sterile instruments in the hospital. It's a hybrid material of a plasticized paper, and anytime you have a hybrid material, it's hard to recycle that. So the blue wrap traditionally always just goes to the landfill. We thought we had really gotten rid of blue wrap by converting to these rigid instrument trays that are sterilized and brought to the room like that, with no blue wrap on them at all. So I thought, great, we've got this problem solved. But when we looked, we're still buying 12 tons of blue wrap a year. So our waste manager actually found an outfit that will collect the blue wrap and recycle it into reusable materials. And we're currently collecting about 225 pounds of blue wrap every week. We can only collect the clean stuff that gets taken off the trays before the patient enters the room. So we're collecting probably about half of our blue wrap. And so hopefully all of you know, recycling is really not the best idea. The best idea is to reduce. So we are working on trying to get rid of even more of the blue wrap. And based on this analysis from the vendor who supplies the rigid trays, the hospital would save about $95,000 a year, or almost $900,000 over 10 years if we converted completely to the rigid containers versus blue wrap. Now, with everything, there's always more to the story. So yes, we can save a lot of money, but there are logistic concerns. You need to have enough space in your central processing area to keep all those trays. There are especially instruments that will not fit in those trays. Excuse me, and you need to have the sterilization capacity to sterilize the trays, which are bigger than the trays wrapped with blue wrap. So there are some hurdles you do need to consider. The next issue are volatile anesthetic gases. So I didn't realize this. I think most doctors don't realize that the global warming potential of these gases is significant. So carbon dioxide has a global warming potential defined as 1. And the volatile anesthetic gases have orders of magnitude greater global warming potential than does carbon dioxide, with desflurane being far and away the worst actor. 1 Mach hour using desflurane is the same as driving a car for 192 miles. So our anesthesiologists got together and removed desflurane from the formulary, which the hospital had been pushing to do for years anyway, because it is also way more expensive than the other gases. And one of our anesthesiology climate champions has been nudging the department to move to low flow anesthesia, where they use lower concentrations of the volatile gases. She presented at Grand Rounds. Our EPIC folks put pop-up reminders on the anesthesia machines to remind the anesthesiologists to decrease their flows. And we're measuring the gas use before and after these interventions. We're also working to get nitrous oxide out of L&D. It's been very popular with the staff and the patients, but studies show it's really not very effective. So we're trying to get rid of that completely. Another area that we've worked on is energy use reduction. So the air in operating rooms is exchanged routinely 10 to 24 times an hour typically. And this wastes all the heating and cooling that you put into that room, then gets vented out into the environment. There are systems that can collect some of that. We installed half of that when we built our new ORs, but really we lose a lot of energy when we do those exchanges. It turns out the industry standard states that the exchanges can go down to 6 per hour when the room's unoccupied. But when we built our ORs, they just ran every one of those rooms at 24 exchanges per hour, 24 hours a day. So if we would decrease our air exchanges when the rooms are empty, we could save 2.8 million kilowatt hours per year, keep 589 tons of carbon dioxide out of the atmosphere, and save the hospital $50,000. So naturally, anything you want, anytime you want to change anything in the operating room, there's a lot of pushback. We've done 4 different pilot studies measuring the heat, the humidity, the air pressure, and the particles in the ORs by turning down the number of exchanges. And what we've done in our pilot number 4, which actually looked at 4 ORs for a week at a time, we found that the exchanges actually don't affect the particle counts at all. The particle counts are affected only when people are in the room. So we've got a proposal out to cut our exchanges down at least to 12 per hour when no one's in the room, even though the data show 6 is just as good. The OR staff is balking, and we've got a meeting set up to try to convince them at least to reduce some of those exchanges when the rooms are empty. Other things we're doing, so all new buildings on our campus have to be certified by LEED, which is Leadership in Energy and Environmental Design. I think they need to be at least a silver, gold, or platinum, which is the highest of the certifications. And I don't know if you know about LEED certification, but it looks at multiple different environmental factors in the building design. And once you get certified, they do come back and do an audit a year later to make sure you actually are meeting the criteria that the building's designed to meet. We've replaced most of our lighting with LED lights, which have much lower energy consumption. We have been doing energy audits in our building and scheduling lights and thermostats to match building and room occupancy. And we're currently working on trying to cut down the energy consumption of idle imaging equipment, particularly our CT scanners and MR scanners, which burn a lot of electricity even when they're not being used. The MR scanners are particularly difficult because you have to keep their magnets cool all the time. So we're going to install current meters on a couple scanners. We're working to try to educate staff to make sure those machines are being turned off when they're not being used, making sure we're using the low power modes when we can. And we're trying to write into the purchasing ideas to consider the energy consumption in lower power modes on the equipment we're purchasing. We're in the middle of a huge capital building program right now, where hopefully we can buy more efficient imaging equipment for our new facilities. And our institution set a goal of decreasing our energy use efficiency by 2% per year. Energy use efficiency is the energy use per square foot. And the dotted line is that goal. And the orange line is what we've achieved. And we've actually exceeded that goal every year. In 2020, we dropped our EUI by 3%. So we're making progress there. Next area is food. So I'm not sure, again, how much folks are aware, but food, growing our food and distributing our food is has some of the biggest negative impacts on our environment of all human activities. And our food service has actually been a leader in sustainable food. So I wanted to include this photograph of smiling Santana Diaz. He's our executive chef. He is incredibly motivated on sustainability in the food that he produces for our staff and for our patients, and has received multiple awards. One of the few, if only, hospitals to get some of these awards that frequently go to very sustainable restaurants. He's done that by buying our food locally, which fortunately is relatively easy to do in Sacramento, reducing the meat on the menu, and getting 99% of our fish from sustainable fisheries. And this just looks at how UC Davis Health compares to our peers, the main campuses of the UC system and health campuses, and by far and away, we are leaders in the amount of a percentage of the money we spend on our food that is sustainable as defined by Practice Green Health. And then just briefly, other efforts that we have worked on, we're trying to get rid of single-use plastics. We've written policies both for our food and retail services and our clinical entities. Food services moving along rapidly to get rid of disposable stuff. The clinical part has been a little tougher. We've got more pushback there, but we'll continue to work on trying to get rid of single-use plastics. We are collecting data on the energy savings from virtual clinics. Those virtual clinics really took off during the pandemic. We've got a couple of researchers who are collecting data from all 5 UC health systems and working to publish a follow-up on a paper they wrote on that topic before the pandemic. We are able to get the institution to fund 3 resident sustainability projects per year. So the residents write up a protocol, they are peer reviewed, and if they're good enough, they get a stipend to do the research for a year, and they also get support for statistical analysis from the institution, and then they're expected to present their results at a quality improvement forum, which we have every spring. We are working to get our recycling much more robust than it is now, and we're trying to get our composting going, seeing that is mandated by California law. So there's a couple things we're working on currently. So to kind of wrap up, how were we able to do this? We do have some advantages in the UC system. There is a infrastructure for sustainability throughout the entire UC system through the Office of the President. Each campus has its own infrastructure, and then each health system also has its own infrastructure. Our health system that includes a director of sustainability and a sustainability committee. We work with Practice Green Health, which I've mentioned a couple of times before. Practice Green Health is a subsidiary of Healthcare Without Harm. They provide educational materials to help hospitals and medical practices learn how to be more sustainable. Probably a bigger thing they do is they collect data from participating organizations in these 11 different domains. And then every year, if you submit those data, they give you a report card so you compare how you are doing. In our case, they compare us to our sister UC institutions. They give you a median for give us a median for the UC institutions. It gives a median for all the practice health care participating institutions, and we can compare how we're doing year to year and how we're comparing to our peers. And they also pass out awards, kind of like getting merit badges when you're a scout. And I don't know how much this is really worth, but the leadership and administration like it. Our institution won 4 of those in 2020. Practice Green Health only gave out 1 in 2021 because they didn't get as much data with the pandemic and weren't sure what to make of some of the data, but they're going back to the full reporting for this fiscal year. So these are the good things that made it easier for us to make some progress, but it's not all rosy. So our director of sustainability has no staff and really has no budget. And in fact, she recently left to take another job with our local utility district, and we're recruiting for a new director. So based on that, I started a grassroots working group. We actually had our first meeting 1.5 years ago, and most of what I've presented is stuff, that's all stuff that we've been working on. And I recruited our membership by giving a grand rounds presentation on the environmental catastrophes that we are all facing. And we're able, and then at the end, put in a pitch to see if people wanted to join this group. We divided, we had a first meeting, thought about what areas we thought we might be able to get some traction on, divide into subgroups. The first thing we did was we explored to see what was actually already going on in the health system, and we're pleased to find there were some efforts which we then tried to help move along. And we continue to have monthly meetings where we report on our progress and try to keep the constituents engaged. So I think it's very important for physicians, nurses, employees to be very involved in these issues if they care about them. So our organizations may set goals. UC is great at setting goals for carbon reduction and waste reduction and so on, but it's the people who actually work in the institutions who make the changes. And particularly in a hospital, the administration really doesn't know where the opportunities are because they're not doing the work. We're the ones who are doing the work. We're the ones using the energy. We're the ones consuming the supplies. So we're the ones who see where the opportunities are, and we're the ones who are going to have to accept the changes to make our practices more sustainable. So if you're starting off on this, I would suggest going first after the low-hanging fruit. And by that, I mean things that save money. So you could see on several of the examples I gave, I talked about the financial savings, because if you go to the administration and say, I've got this great idea that's going to make us more sustainable or less polluting, but it's going to cost you $1 million, it's harder to get them to sign up. If you show them that you can make your practice more environmentally friendly, still provide good patient care, and save money, they're very easy to convince. And fortunately, you frequently save money when you use less energy, when you generate less waste, when you replace disposables with reusables, when you use less water, when you purchase reprocessed items. So it turns out lots of the stuff that we want our institutions to do actually have money savings built into them. So in conclusion, I would just like to reiterate that healthcare is a major contributor to the environmental harm we are experiencing. And as everybody in this group is aware, this affects the health of our patients. And if we truly care about our patients' responsibility to address this, responding to this is part of our responsibility as healthcare providers. So I would say we have an obligation to act for the environmental benefits. And if we want to be good financial stewards of our healthcare systems, we should act for the financial reasons alone, even if you don't care about the climate stuff and the environmental stuff. So that is the end of my presentation. I am hoping that there will be some questions.
Bill, thank you so much. That was awesome. And your work is incredible. And as a non-surgeon, it was bringing me back. I'm like, wait, ligature. I've heard that word before. I'm Googling what these things are. But thank you so much. Oh, awesome. Okay, Jonathan, I see a hand. I think we can we're a pretty small group. So why don't, just unmute.
Yeah, the oral questions are way better than written questions if we can do that.
Thank you so much for that really educational presentation. Yeah, I was wondering if you could talk a bit about how much measurement needs to be done to reduce scope 3 emissions, like in a systematic way. Because like I worry a lot that like if it will be really burdensome to measure a lot of scope 3 emissions, but also it's important you can't like reduce what you don't measure. So I'm wondering like how you're thinking about that. Like is like a small private practice clinic going to also be able to measure and do their scope 3 emissions in a way that's not burdensome?
Yeah, that's a really good question. And you may be aware the SEC, the Security and Exchange Commission, is discussing right now potentially mandating that basically all companies that sell stock have to measure and publish their scope 3 emissions. And there are multiple startups that are working on how to measure those emissions. And you can't, the common saying is you can't reduce or you can't fix what you can't measure. So measuring this stuff is important. And measuring the scope 3 emissions is much harder than the scope 1 and 2 emissions. So that is a problem. I can tell you from a practical standpoint in my own efforts, I'm just trying to move the needle. So I think they're obvious, all the things I've pointed out, I think are pretty obvious efforts moving in the right direction. I guess I feel like I'm a little bit of a tangent. Our procurement officers are supposed to consider the scope 3 emissions as 25% of every purchasing decision. And I'm not sure they do because I'm not sure how they do that. So how we measure scope 3 emissions is hard. There are multiple companies working on how to do that. I've not seen a lot of that get into the healthcare space yet, but I think over the next couple of years, it's going to be easier to do that, but it's never going to be really easy. So I don't know if that's a really good answer to the question.
No, that's so helpful. Thank you.
Yeah, Margie. You're still muted.
I'm on mute.
Yeah,
thank you. That was an awesome presentation. You've done so much, accomplished so much. I'm just wondering if you run into administrative pushback. I mean, did you have to ask permission? How did you start? How did you get through the administration stuff? Yeah,
that's a really good question, and that is what I consider one of my superpowers in this. So I didn't ask anybody. So this just came up. So my saga is when I was looking for something to do in my retirement, I got roped into a committee that was set up to include climate change and sustainability in the health curricula of the UC schools. And so I can do that. And I'm an educator and started giving grand rounds lectures on the topic. And after doing that a few times, I felt powerless because we've been talking about this. They were talking about this when I was in college and I'm an old man. So we've been talking about this for decades. And I felt this felt unsatisfying. I wanted to start moving the needle. So I thought, well, how could I make a change? I can do stuff in my own life that's teeny. But if I could make the place where I work change, that would be even better. And so I just started recruiting people to do this. And I worked there for a long time and had a fair bit of responsibility. So I knew a lot of people. So I knew doors I could knock on, but I've completely, I keep saying our group is completely without charter. So we don't need to go to the academic senate to get approved members. We don't need to answer to anybody. And so it's entirely grassroots effort, which I think is not a bad way to go. I'm also on the official sustainability committee and a couple subcommittees, which is great, but they don't, to me, they don't do nearly as much as what our grassroots organization does. And I think if you want to do it, you need to know the movers and the shakers. So I actually have, and I've got a few department chairmen in my group, in our group. So we have some access to the COO, we have some access to the vice chancellor, we have some access to the dean. So we can knock on doors and get those folks to answer when we need to. But I've been also amazed just the middle managers who really do stuff, the analysts and the department managers and stuff. I call them up or send them an email, ask them stuff, and they just do it. Even though they don't work for me, I don't even work there anymore. So I think if you figure out who you need to talk to and approach them, I think the reason they've been responsive is a lot of people care about this and are frustrated. They don't know where to go. I say, hey, we've got this idea. Can you do analysis? I went to the value analysis. Can you do an analysis on what it costs to buy the sterile OR gowns versus disposable gowns? And I got in touch with some vendors, got some numbers from them, sent them those numbers, and he's crunching those numbers for us. So people will, if you approach them appropriately, I think they'll respond well. I hope they will. I hope that answers the question.
Thank you.
Yeah. Yeah, Amanda.
Yeah, I can ask a question. So I would be curious to know what advice. So I don't work for a large medical system. I work for like a freestanding clinic.
Yep.
That is, I have no idea what our carbon footprint is. It's probably minuscule in the grand scheme of things, but we also are, we don't recycle, we don't compost. The only thing we do is we use reusable gowns.
Yeah.
Yes. And like, what should we start with? What should I start? And I don't know that anyone else cares other than me.
Yeah.
So
that's, hopefully you can get them to care. So I anticipated this question because my personal experience and efforts has been in a hospital because I was a hospital-based physician. That's what I know. But I recognize that many on this call would be primary care doctors. So this is a paper that was published this year out of Switzerland, looking, you can see my screen, yes? Looking at the carbon footprint of primary care practices. And so it's Switzerland, it's different than us. But when they looked at, and they looked at 10 different practices, from like 1 to 4, or like 1 to 10 practitioners, average about 4 practitioners, 2 doctors and 2 nurse practitioners or PAs basically on average. And they did a very extensive analysis. So what they found was 75% of the carbon footprint was from the patients and the staff getting to the clinic and the heating of the clinic. And only 25% was everything else. So for an outpatient primary care clinic, at least in Switzerland, the biggest impact would be on mobility. Now, granted, they excluded pharmaceuticals, and other studies have suggested that pharmaceuticals account for 10 to 22% of the healthcare footprint, and that's probably even a bigger percentage for primary care based on a study published last year.
Is that plastic? Is that like the waste, do you think, or like the production cycle?
Oh, that's the whole thing. So
Okay.
it's the raw material extraction, it's the manufacturing, packaging, distribution, and waste. Pharmaceuticals are a big part of the whole healthcare footprint, and pharmaceuticals are a big part of the primary care practices. They didn't find a lot of carbon from, doing tests in your clinic or the stuff you use to treat lumps and bumps and stuff. The consumables weren't very much. Courier mobility was 10%, but that was mostly for emergency stuff. They said the couriers that did standard routes, they didn't burn a lot of energy, but the ones when you had to do a specialty thing and a one car came just to drive something back and forth was a big issue. And I found this very interesting. So 46% of the total carbon footprint was from the staff and patient going back and forth. And it was more from the patients than the staff, obviously. But in Switzerland, only 63% of the staff drove their car and 75% of the patients. I suspect those percentages are much higher in the United States. And 99% of the total carbon footprint from travel came from those in the car. The ones who are taking the train or riding the bus we're only altogether only 1%. So I suspect that the mobility for us, if you want to make a difference in your practice, if you get people to start riding their bike or taking public transportation, or even probably more effective, use more virtual visits so your patients don't have to come. The other thing they talked about in the paper is distributing our clinics, get them closer to where the people live. But I found that interesting, that it's really the transportation that affects the private practice more than anything. Ashley?
Thank you, Bill. This is awesome. I'm one of your greatest fans. I have a question. So I've asked this to like Mark Fudernick, who I think is still on. And one of the things we keep thinking about is, so Kaiser has a scope 1, 2, and 3 emissions inventory. Hardly anybody at KP even knows it. But one of the things we've like been brainstorming about, and we're not there yet, but if our members decide that we want to work on decarbonization, which my hunch is yes, one of the kind of campaign opportunities that I could imagine is all of us enabling our institutions to do these inventories, to know where is the highest yield work to do. Do you think that would be a good idea?
I think it's a great idea, but that also speaks primarily to big institutions. So a place like Kaiser potentially can find the budget to look and that kind of stuff, because it's not going to be inexpensive to try to audit and get an inventory and get a handle on scope 3. And to truly measure scope 3 emissions, you need to get a lot of information from those suppliers. So they have to be measuring it also. So it's not a simple task. I would think for say a small 100-bed or 60-bed freestanding hospital, that might be challenging to find the budget flexibility to do that. A place like UC or Kaiser Permanente absolutely could do that. And it's going to be these big institutions that are going to push us. The Harvard, the Brigham Mass General Coalition, for instance. It's going to be those kind of institutions that are going to be able to push these efforts. I mean, a similar thing on a similar vein, one of the projects I've been hoping to work on, I'm actually going to have a meeting next week on, is seeing if we can leverage the University of California health system purchasing power to get rid of some of the unnecessary packaging in the medical stuff we get. Our institutions have done a good job of getting rid of the boxes, the big cardboard. That stuff comes in toters that go back and forth from our big suppliers, so that's great. But every little device, every little item comes in 3 layers of plastic and cardboard and package insert and blah, 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 blah. And no single institution can do that, but hopefully if you get some big purchasing power like KP or UC Health, maybe we could start getting some traction on that.
Yeah, I hear you. When I personally was looking at buying solar when I lived in DC still, the World Wildlife Fund was helping to do a group purchase. And so they were getting like multiple homeowners together. And then we were going to pick a solar, installer and get a discount if we did it together. And so one idea is like, maybe if we get 10 of our institutions to say, we'll do this, then we could get a discount from somebody who does the inventories like True Cost or NG or what is it? Mazzetti is another one. And then we can like broker that deal to help them. Cause this is hard. Like this is, the new process is there's a lot of inertia, but that seems like maybe something we could do as a group where we could get a discount for that inventory cost.
Yeah, scope 3 is hard everywhere. And again, there are lots of upstarts who are working on this. So hopefully they'll get figured out, but it's always going to be a challenge, I think.
Meghana and then Jonathan, and then we probably have to close it down.
Hi, thank you so much for that excellent talk. I wanted to ask 2 questions. One is sort of, I really appreciate how you really focused on your home institution where you had the network and the relationships to sort of be able to leverage and create change quite quickly, it sounds like. I'm at UCSF and UC Berkeley, right? And at UC Davis, in general, UC and some of these large institutions are quite bureaucratic. So is there something that you would, that you've worked on that you think would be effective at the policy level, either at the national, state level, or even at the UC level specifically, that you think could be a viable thing to tackle in the next 6 to 12 months? That's question one. Question two is, or maybe it's more of a comment, is that, so I'm part of the Center for Health, Climate Health and Equity, which is a new UC-wide center, and I'm the Berkeley faculty rep or whatever. And we're starting some research around the economics of healthcare decarbonization. And unfortunately, sometimes you have to be able to show the fiscal benefit before people who are reluctant customers will come around for something that's like obviously the right thing to do, right? You've seen this and you've obviously leveraged that very effectively. And I was curious if you had any names, and I can talk to you offline as well about health economists who look at this. The reason I bring this up is because it seems like when you look at a lot of health economics data, it seems to not internalize a lot of the issues that come up in healthcare that are causing a lot of pressure. I had a conversation about this yesterday about how health, like from a payer perspective or a health economics perspective, the massive epidemic of burnout, for instance, that's afflicting healthcare is completely invisible, right? And I think analogously, waste when it comes to outside of like, oh, we're saving money with reusable gowns or something, like the economics of this being an unsustainable model, all the externalities that are not part of our calculus and how you make money in healthcare is part of the issue. So I'm just curious if you have any thoughts about health economists working on this, or just to be able to reach an audience that is not your typical attendee of your lectures,
Yeah, two very good questions. As far as advocating for big system-wide changes, there are actually multiple groups working on that now. There's the Green New Deal. I don't know if you've been in touch with them. You see Green New Deal, that's working multiple efforts at the Office of the President level. And there are other groups, a group that has, so UC has committed to being carbon neutral by 2025. They're trying to actually make it carbon zero. And there's a group working on that. I have been involved slightly peripherally with those because I still remain frustrated, similar to the frustration with trying to get government to move. It moves slowly, and setting goals is all well and good, but the goal doesn't get us any closer. And so I feel my energies are better used towards trying to move the needle, even on a small level. So that's been more satisfying for me. So I don't have I can tell you there's a bunch of groups out there trying to push the bigger process. And if you want to get involved, I can give you some contacts. As far as a health economist, I've not worked with one. I'm sure there are health economists out there working on this. I'm just not aware of any. So, and a resource for you might be Dr. Gandhi, Seema Gandhi at UCSF, who is the medical director of sustainability, one of 9 medical directors of sustainability in the country. And I'm actually meeting with her next week for the first time, one-on-one, and she might be able to help you out there. So
great. Thanks so much. Yeah, I've talked to Seema before, but that's a good point. I'll reach out to her again. Thanks.
Yeah.
Jonathan, do you want to see if you can squeeze in one last quick question? We have 1 minute left.
Absolutely. I was wondering if you could point to some of the startups that are like thinking about the tracking and reporting, just like,
yeah, or I'm on this feed from, I think it's through Green Biz, and I just got a note today about these startups. I will forward that to you if I've got your email.
Or Bill, you can send it to me and I can,
okay.
yeah,
I'll send
I
it
can
to
share
Amanda.
it out with the
Okay.
recording.
Right.
Yeah. I was also thinking there, I don't know, there's a group called Block Power that is interested in working on kind of clinics like mine that we've heard from. I'll include a link there too. They're expanding to California. All righty, everyone. Well, Bill, thank you again. This was fabulous. And thank you everyone for joining. And I'll send out the recording. Bill, assuming it's okay, I'm going to share your slides and any of those resources you can get to me, and I'll include it all.
Yeah, and Amanda, I didn't look at the chat, so if there's other things requested in the chat, you got it, just send it to me and I'll try to answer those things.
Okay,
so
I'll save it.
Okay.
Okay, bye everybody.
All right. Thanks everyone.
Thanks.
Bye-bye.